Good morning, everybody. Thanks, Trish. And thanks to the organizers, Doug, Gerd, Iveta, for inviting me here to talk about this topic here in Freiburg, where I'm not exactly for the first time. But it's actually a pleasure to be here to see all the well-known faces and new faces, people interested in these topics. Well, I tried to beef up a bit the title that was given to me, as others have done earlier this morning as well, and added garbage in, garbage out, well, a well-known term that might be applicable to the question whether there is any impact of poor reporting on the development of systematic reviews. Actually, I was a bit anxious this morning when Doug started out that he might say everything, and I have nothing left to add later in the morning. But I hope there is still something I can add to that, and I was especially relieved that he did not use the same examples that I will use in the next 15 minutes or so. Let me start with some general statements that may be obvious to many of you, but for some it may be nevertheless interesting actually to set the scene. Systematic reviews play a pivotal role in knowledge transfer from the clinical research, from the research areas to the healthcare practice. I think that's not debatable. They are considered a very high level of evidence in the pyramid of levels of evidence that some of you may know. The value of the clinical studies that are the building stones of the systematic reviews and of the meta-analysis, if possible, depends on what we know from the publications of these clinical studies. So it depends on the accuracy, the completeness, and of course also the transparency of the publications. Methodological quality clearly needs to be distinguished from reporting quality. I think that's one of the achievements of the reporting guideline initiatives and also of Equator, to really point that out and make that clear, and that hasn't been clear in the earlier versions of reporting guidelines, or the precursors of the reporting guidelines like we know them today, like CONSORT, START, STROBE, PRISMA, etc. Good studies may be reported badly. We just don't know what has been done, although things have been done properly, and vice versa. Bad studies may be reported well. I think we aim for the second. We want to, and that has been also mentioned in the discussion this morning, and to reply to one of the questions, that if there have been problems in the study, at least we want to know about them. We want to know them transparently, and that shouldn't be, that openness by authors shouldn't be a reason to reject the paper. It's still a very good report, although a research group or a single researcher might have run into trouble during the conduct of a study. I like to think actually of this flow of information in terms of a knowledge generation cycle. You have the, don't know if I can point with that one. You have the research activity on the top, and then you have the publications. After the publication, you have a dissemination, secondary publications, blogs, whatever. And then you have the utilization of the research evidence, either to trick or to inform other research, or to inform decision-making into practice, in the practice, especially in healthcare. Well, poor reporting is a problem here between the research and publication. It's not a problem of getting the message out once it is published to those who might want to use it. It's between the research and the publication. And of course, the systematic reviews are down the road one of the products where the research evidence is used and are actually hampered poor reporting. So, but what do we actually know about poor reporting so far? There are, I would say, basically two types of empirical studies. There are the studies that analyze reporting quality, especially of trials, using, for example, consort items as assessment criteria. There are also these kind of studies on other types of studies like diagnostic and observational studies. And I'm less convinced that we should stop doing these studies, as Doug has mentioned this morning. If we don't do these studies and point to that problem again and again, people might think that it's fine now. We have all these guidelines, and there is evidence from the 80s and the 90s that reporting was poor, but now it's fine. So I think we still have to do these studies. Maybe we don't gain any brownie points in terms of originality from the editors, but I think it's important to do it until, well, the problem is settled, maybe for the 20th anniversary of Equator in 2028, as has been mentioned this morning. There is another type of studies on poor reporting, which are studies comparing additional sources that may be available to subsequent publications, for example, study protocols, and I'm showing a bit of this evidence. There's one study that has been done by Anwen and Doug, both here today, and they used a rather large sample of randomized trials published during 1 month in the year 2000, and all indexed in PubMed, and actually showed that there is a failure to report the key aspects of trial conduct and well-known and undebatable important items like random sequence generation or concealment of allocation are not reported in this sample of unselected sample of randomized trials. So that's actually the first type of research I mentioned in the previous slide. The second type is studies that actually compare different sources or try to add a second source of information to identify the problem of poor reporting. I find this graph actually quite impressive from a paper, a study that has been published in BMJ in 2004. A smaller sample of 56 phase 3 trials that have been done by a publicly funded research group, the Radiation Therapy Oncology Group, and the corresponding 58 publications. And actually what they show here is that for important items that should be reported, for example, adequate allocation concealment, of the 58 publications, only 24 had the information, but if you ask this oncology group for the information, or you look at the protocols, this information is available. So it's really a problem of poor reporting, and not that, for example, in that case, allocation concealment has not been done. It's really this gap between the conduct and the reporting. For other items, for example, the reporting of dropouts, it was just fine. 53 of them had actually reported about dropouts, and when this group was asked 53 studies, there was evidence of dropouts. So when we talk about poor reporting, it's not poor reporting of anything and everything, it's poor reporting of particular items. And well, the question is, how important are they then, for example, at the stage of a systematic review. Another study done by Anwen and colleagues, published also in the BMG. I'm not only citing BMG studies because Trish is chairing the session, but I think finally there is some clustering of these interesting studies in the BMJ. Actually, study that is based on the cohort of trials that have been approved in Denmark in the mid-90s, and also there discrepancies were found between the protocols and the publications, and you see here it's about the same issues of trial methodology that were underreporting, and also interim analyses were actually stated or planned as outlined in the protocols, but then never mentioned in the corresponding publications. Here in Freiburg, we were able to do, in the context of a project that has been mentioned in the beginning this morning, a study that is actually focused on selective reporting, but we used it to look at the description of the study populations as defined in the eligibility criteria. And we also used a sample of protocols that we could access in collaboration with the Research Ethics Committee here from the University Hospital of Freiburg, and all protocols that have been submitted to that committee in 2000, the corresponding publications, and actually we extracted all the informations on all the single pre-specified eligibility criteria. So you see that's more than 1,000, and then looked from the protocols, and then looked whether that matches with the publications. And it was interesting to see that there were differences in all 52 trials. There was no one single pair of definitions of the study population, meaning eligibility criteria, in the protocol that matched exactly with the publication, with all kinds of changes. The most frequent one, that eligibility criteria were missing, but also that they were modified. And interesting, also eligibility criteria that were added in the publication, although we also looked at the amendments. So that is not because the eligibility criteria have changed during the conduct of the study. So you really wonder where these eligibility criteria come from. And for a systematic reviewer, I mean, it's difficult to sort out what the trial population was actually, especially if a reviewer do not have access to unpublished information. And as we know, case mix and study population is one of the reasons for heterogeneity in meta-analysis. So what are the consequences, as I have mentioned already, of poor reporting? For the review process, it hampers the critical appraisal. The proper use, for example, of the risk of bias tool as we use it in the framework of Cochrane reviews becomes difficult. Study quality may be misqualified. You might not be able to decide whether that is a good study because you don't have the elements, although it has been conducted properly. And studies may even be excluded from meta-analysis because these important methodological aspects cannot be elucidated. For the evidence base, it means that the existing body of data may be underused or not used at all, because simply you cannot assess it properly. And that actually is one factor that adds to what we know already, which is the prevalent underreporting of trials. I mean, there is already a waste of evidence that is there, and which is not accessible because it's not published and maybe only accessible for regulators, but not for other users. And the fact that studies might be included because we can't make sense of the reports adds to that. For the decision making, it means that healthcare professionals, but also patients or their families, have to make their decisions on a weaker evidence base, which is a clear consequence from that. So here are from the Cochrane reviews 2 quotes, and they are particularly, I was glad to have found another one than Doug has showed this morning. So a study on treatment of schizophrenia the author stated that unfortunately every study failed to describe adequate sequence generation and allocation concealment, so they can't tick in the risk of bias tool whether there were problems with that, and or whether the quality was acceptable for these points. And in another study on mistletoe therapy in oncology, the author stated that it was unfortunate that many studies reported data in an intransparent form, and then added the use of structured abstract and, of course, application of the concert guidelines would have improved the reporting quality considerably and probably make the life of these reviewers a bit easier. Now, does poor reporting really mean bias in systematic reviews? I mean, we know that poorly conducted studies tend to overestimate treatment's effect. But how about poorly reported studies? I mean, if you make this distinction, does it mean that it also introduces bias? I mean, these questions for me are not really resolved. Does poor reporting itself cause bias? In what direction? Is it in terms of the consequences for systematic reviews and for example, combined estimates in meta-analysis, is it the same? Do we have evidence from empirical studies on that? I'd be interested if you know about. I found this one recent study from a very important project that the Liverpool group, together with Doug and others, have set up, the ORBIT study, another nice acronym, actually. And I won't go too much into the details here because Paula Williamson is on on the podium later today, and she might present her own data better than me, probably. So actually, just briefly, they looked into Cochrane reviews that were newly published, so no updates in 2006, at the included trials, and found that there is evidence of outcome reporting bias. And that if you, and that's the second last point here on that slide, if you do a sensitivity analysis of reviews and repeat the meta-analysis, there is some evidence that there is a reduction of the treatment effect by more than 20% when you adjust for this outcome reporting bias. But selective outcome reporting and outcome reporting bias is not exactly the same issue as poor reporting. So that might be 100% applicable to my question here. What may be future strategies for the next 16 years until the 20th anniversary of Equator? Of course, we need to further improve the reporting quality of primary publications. We need to complement the information we have by information which is not included in the publications, for example, through author contact. And I'm also wondering, this is always a problem in Cochrane reviews, to get good information when you contact authors. And I'm actually wondering how this mechanism can be maybe more formalized and improved. If there should be yet another written commitment upon submission that you're willing to answer questions when you are contacted after publication or whatever. Future strategies might also include to make study protocols accessible. There are initiatives for that, and that has been mentioned also this morning, to finally make the clinical study reports that are much more detailed than the journal articles accessible. Normally they are confidential. They only and there is no interest by funders, by sponsors, commercial sponsors, to disclose them. They are submitted to the regulatory bodies, but they may actually even replace publications as the primary data source, at least for reviews. So that has been alluded to this morning as well, that maybe the role of the publications may change. They may more be on the side of entertaining and informing people, but if it comes to really digging into the details of methodology and the detailed results, it may be necessary to go to, say, technical reports that don't have to actually comply with journalistic demands that are posed on a manuscript. And there has been one example for a review already. Most of you might know the Tamiflu review that was published as a Cochrane review earlier this year. And if this becomes using the, I must say, using the clinical study reports as the primary source and not the publications as the source for reviews. This might be, at least for Cochrane reviews and also other a change of paradigm in the way how we conduct systematic reviews. A few words just on poor reporting of systematic reviews themselves. We have evidence on that, early evidence even from the 80s, 20 years later, still in a sample of systematic reviews that were indexed in PubMed. I think Dave Moore and colleagues found that important items like the assessment of publication bias, important in the context of systematic reviews, are not well reported. I would say if we hadn't this new study, well, as I said before, one could say, well, that was in the 80s, and now we have nice reviews, and the problem is settled.
You're nearly out of time, I'm afraid. Just a minute or two
finishing.
left.
Okay,
Sorry.
thanks. Reporting quality of systematic reviews, there is the analogy with the reporting of primary research. Poorly reported systematic reviews as primary studies may not be suitable for further use, for example, in clinical guidelines. And of course, initiatives like the PRISMA statement that followed on quorum have helped to tackle that problem. To go back to this knowledge generation cycle, actually, if you replace research by the primary research activity by systematic reviewing, you still have the problem of poor reporting of systematic reviews here, and down this cycle, in the utilization, for example, of clinical guidelines, you run into problems if the systematic reviewing is not properly reported. There's one last initiative I want to mention here that actually is very recent in the context of Cochrane. That is MERCIR. That's actually a collaborative effort to set up guideline standards for the reporting, but also for the conduct of Cochrane intervention reviews. A very long list, longer than PRISMA, 108 items. And one innovation here is that there is a distinction between items that are mandatory and others that are just highly desirable. It looks like this. It's really fresh on the website of the Cochrane collaboration, and I hope that when we celebrate the 20th anniversary of Equator, the products that we and material that we talk about, meaning primary research reports and systematic reviews, do not look like this. Thanks very much for your attention, and I'm happy